Hello, and welcome to today's Lunch and Learn, Shoulder Pain, Don't Shrug It Off. I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital and Meritas Health. Thank you for joining us. Shoulder conditions and injuries can cause pain so severe you struggle with everyday activities. Sometimes physical therapy is the solution, but other times orthopedic surgery is needed. Our expert speaker today is Dr. Craig Satterlee, an orthopedic surgeon with Orthopedic Health of Kansas City. He specializes in shoulder and elbow injuries. He will discuss the progression to surgery through modern treatments. He'll look at the indications, options, and benefits. He will explain what to look for in an orthopedic surgeon. Dr. Satterlee is board certified in orthopedic surgery. He received his medical degree from the University of Missouri in Columbia, where he completed his internship in surgery and residency and chief residency in orthopedic surgery. He was then the Annie C. Kane Senior Fellow in Shoulder and Elbow Surgery at the New York Orthopedic Hospital, which is part of Columbia Presbyterian Hospital. He's a fellow of the American Academy of Orthopedic Surgeons. Dr. Satterlee has served in executive roles for a number of orthopedic medical organizations. For the prestigious American Shoulder and Elbow Surgeon Society, he is also the only member from Greater Kansas City. A widely published researcher and a prolific speaker, Dr. Satterlee also was a clinical assistant professor of orthopedic surgery at the University of Missouri in Kansas City. If you have questions about shoulder pain, submit your questions using the Q&A feature below. We will get to those in the end. Please join me in welcoming Dr. Satterlee.
Well, thank you, Dr. Reinches, and thanks for everybody who's in attendance today. I really appreciate you tuning in or zooming in, as we say these days, to this presentation. So we're going to talk today about shoulder pain. Don't shrug it off. So shoulder pain over time, the causes have remained the same. The fractures look the same. The tears from dislocating your shoulder look the same. However, the treatments have evolved to what we consider as non-operative and operative treatment. That is to say, we don't really talk of it as conservative or aggressive anymore, because sometimes non-operative treatment can be aggressive and operative treatment can be the more conservative choice. So I'd like to have a little lesson on the anatomy of the shoulder. And for that purpose, I'll direct your attention to the diagram on the right. This shows the bones of the shoulder, including the humerus, as outlined here with the laser pointer, the scapula, which a lot of people call the shoulder blade, and the clavicle, which is also known as the collarbone. There's structures that run from bone to bone called ligaments, as outlined in the various arrows on this screen. And next, on top of these, we have what are called the muscles of the shoulder. So in the diagram on the left, we see the front muscles that are on top of those ligaments called the rotator cuff muscles. They run from the shoulder blade to the upper arm. There's one in the front is labeled called the subscapularis, one on top called the supraspinatus. Also of importance is what's called the long head of the biceps, which is depicted in the lower portion. And it can be involved in a lot of pathologies of the shoulder. I'll take your attention to the diagram on the right, and this shows the back rotator cuff muscles, one called the infraspinatus and the other the teres minor. They help with rotation of the arm and elevation of the arm. When we look at the diagnosis of a shoulder condition, and this is probably the most important part, we look first at the history. Like, how did you hurt your shoulder? Or did it come on insidiously? Insidiously means, as Forrest Gump would say, for no particular reason. There's also the physical exam. which guides our further diagnosis and testing. The physical exam is important because shoulder pain where you feel it is not well localized. It can be referred to the front of your shoulder, the back of your shoulder, and down your arm towards your elbow. So the things that are provocative, that is, cause the pain when we examine you, are very important. And then we use certain tests to confirm the diagnosis or help guide us further in that diagnosis. Probably the most important thing is an X-ray of the shoulder. It shows us the bones in detail, and it can show us other associated problems such as a calcium deposit or something of that nature. The MRI is important to look at the soft tissues of the shoulder, especially if you have, for example, a rotator cuff tear or a tear of the labrum of your shoulder. But it's not the end all. The sports page, when you read it, would make you think the MRI is really the most important thing, but really the history, physical, and all of these tests in conjunction are what's important to make the diagnosis. We use a CAT scan sometimes for fractures, or if we need to confirm a diagnosis or look at particular anatomy when doing an arthroplasty. An EMG and an NCV is a physiologic study of the nerves to the shoulder and arm and help with detecting those type of injuries. And lastly, most people don't think about it, but arthroscopy, where we're actually at surgery, is a diagnostic tool because we can see things that sometimes don't show up on the MRI or the plain X-rays. So what about treatments in general? Well, often activity modification is part of the treatment. You know, like they used to say, if it hurts, don't do that. Physical therapy is extremely important, and it's not to make the patient strong. It's to stimulate the blood supply and promote healing in certain conditions. And in other conditions, it's to assist with stretching and relief of pain. We also use medications and therapeutics. Oral medications such as analgesics, that's pain relievers, like Tylenol, or anti-inflammatory agents for certain conditions. And now available are topical medications, either to relieve pain or as an anti-inflammatory. Other medications and therapeutics include injections, and you've all heard of the cortisone shot. Sometimes it is just to relieve inflammation, but sometimes it actually treats the condition. Viscosupplementation is hyaluronic acid injections. Well, that's really artificial joint fluid. It's used in arthritis. Platelet-rich plasma, where your own blood is centrifuged, and we take the platelet off to get growth factors. And progenitor cells. It's commonly called stem cells, but they're really not stem cells. They're progenitor cells that can differentiate into musculoskeletal tissue. Lastly, for treatment, we use surgery, both arthroscopic and open. So we thought we'd review some of the common conditions that we see in the shoulder. And the first one is what is called adhesive capsulitis, or commonly known as a frozen shoulder. And I probably see at least 5 to 10 people in some clinics a day with this condition. It often has a gradual onset that is insidious, where it comes on with no particular injury. It can come on, though, after an injury or surgery. Anything that can cause pain in the shoulder can cause a release of an inflammatory substance called cytokines, and this can lead to this inflammatory condition. It's often associated with women, 7-to-1 over men, and it can be associated with different medical conditions, such as diabetes, thyroid disease, cardiac disease where pain's referred to the shoulder, and even Parkinson's disease. Well, what's the treatment for a frozen shoulder? Well, for a frozen shoulder, the treatment is guided by the natural history. They took a lot of patients in one great big study, and they looked at doing nothing. How did the patients do if they weren't treated but were followed over time? And they found there were 3 phases: a freezing phase, a frozen phase, and a thawing or resolution phase. Each was 6 to 9 months long, and one progressed to the other. And the vast majority of patients got better over time without doing anything. However, it can take 2 to 3 years. So most of the treatment goal is designed to speed up that natural history. The primary condition is treated with physical therapy for gentle stretching that's guided by the physician and or the physical therapist, followed with medications. Sometimes an injection can actually be curative in this condition because it can work as an anti-inflammatory to cut down the inflammation in the shoulder. We also can use manipulation, which is where patients put to sleep, and or an arthroscopic release. But this is the minority of people, or those who are not responding well to non-operative treatment. So another common condition that we see is what are called labral tears. Now, the labrum, as seen on the diagram on the right, is a lip of tissue that runs around the glenoid, which is the socket. Labrum is Latin for lip. And there can be tears of it from several different etiologies, including instability, like dislocating your shoulder. It can be generative, and it's often seen in folks over 40 years old. It can be traumatic, such as from a fall on an outstretched arm, or it can be from repetitive stress on the labrum, like a baseball pitcher or a softball pitcher. It can be in any location around the glenoid, that is any quadrant. And there's 4 different types. One's where it's degenerative, one where it's torn off the bone. One is a bucket handle tear, and the other, like in a superior labral tear, can be where it goes up into the long head of the biceps. So these are operative photos of mine from an arthroscopy of a repair of a superior labrum, what we call a type 2. The diagram on the left shows a tear of the labrum where I have a small hook. It's placed in the tear and I'm lifting up, and it lifts up off the bone. Normally it would not lift up off the bone. On the diagram on the right, we've put a couple of suture anchors in the bone, and then the sutures go around the labrum to sew that labrum back to the bone. What we're doing is putting the body back in a position to heal. The next thing we'd like to talk about is a very common thing you've heard about called a rotator cuff tear. There can be many causes of a rotator cuff tear, including traumatic, like a fall, impingement, where with repetitive use of the arm overhead, it rubs on the front of the end of the shoulder blade and causes a tear. There's also a genetic tendency for tears. You'll see a patient with a cuff tear and they'll say, well, my sister had a cuff tear, my father had a cuff tear. And there are genetic markers that are associated with rotator cuff tears. There can also be pain with use of the shoulder generated by a cuff tear. And the treatment often starts off with physical therapy to stimulate the blood supply to the cuff. Injections are used rarely if there's actually a tear, because if you get too many, they can actually cause a degeneration of the tissue. And surgery can be either through a small incision called a mini open or arthroscopic. The diagram on the right, on the left side, shows an intact rotator cuff looking at it from the side. And on the right, it shows a tear of what's called the supraspinatus, marked by the blue arrow. And I'm going to show you operative photos from this same point of view. On the left, where it says rotator cuff tear, is actually a tear of the rotator cuff, and the tendon's retracted back away from the bone. What we do is put a series of suture anchors in and then pass the sutures through the tendon. And we hope we get an arthroscopic picture on the right, which shows a rotator cuff repair. And you can see what we're doing is putting the body back in a position to heal. What about the next condition? This is called a calcium deposit, or we call it calcific tendinosis. It can be degenerative or reactive. The cause is sometimes unknown as why people get them. It can be associated with parathyroid disease, which causes an increased calcium content in the body. It's diagnosed on X-ray. There's a treatment including physical therapy, anti-inflammatories, subacromial cortisone can help in this condition. Sometimes we actually put a needle into it under ultrasound guidance called a needle lavage and wash it to try to get it to release. And sometimes we have to do an arthroscopic removal, which we'll give you an example of next. So on the X-ray on the left, you can see the upper arm bone called the humerus and the scapula and the clavicle. And if you look to the side down low, there's a round white density, and that's actually a calcium deposit. The diagram on the right is an arthroscopic picture depicting the same, where we've actually put a needle into it, and I'm pushing the calcium out of the rotator cuff, and it comes out like toothpaste, and that relieves their pain. Now, fractures, I'm not going to go into in particular too much because there's so many different types, and it's usually the kind of thing you know if you have. It's most often associated with trauma. It can be repetitive or stress, and it can be pathologic from some type of metabolic tumor or infection. But if you have a fracture, it hurts so bad, you usually are headed to the emergency room. So another thing that's very common is acromioclavicular joint arthritis. It's pain on top of the shoulder. It hurts when pulling the arm inward. It's treated with anti-inflammatories, anti-inflammatory rubs. AC joint cortisone shots can actually be curative once or twice in about 50% of the people. And there is a surgery to resect the end of the clavicle to make more space so the bone doesn't hit the other bone. The diagram on the right, the left side shows a normal AC joint. That's where the collarbone comes together with the end of the shoulder blade. And the diagram on the right shows an arthritic joint where it's bone on bone. Next topic is glenohumeral joint arthritis, which often presents with pain at rest and with use. There can be a limited motion. The X-ray tends to confirm the diagnosis, and the MRI is used to check the rotator cuff. The treatment is often initially non-operative with medications, physical therapy, and injections. The X-ray on the left shows an arthritic shoulder where there's no space between the ball of the shoulder and the socket, indicative of loss of cartilage. So everybody has an opinion, and these are my opinions regarding the indications for shoulder replacement. The first one is pain despite non-operative treatment and fairly severe pain. The second is uneven or progressive glenoid wear, which is usually detected with a X-ray or a CAT scan of the shoulder. Certain fractures require shoulder replacement, such as one that's in several parts, especially in the older folks. And the goal is to relieve pain and provide better function. So there's lots of arthroplasty options. There's resurfacing of the shoulder joint or the ball. There's a humeral head replacement where we replace the arthritic ball or damaged ball. There's an anatomic total shoulder, and that's where the ball's replaced with the ball and the socket's replaced with a socket. And there's two types, one that has a stem that goes down the inside of the bone, and the other where it has a platform that the bone grows into. And there's lastly a reverse total shoulder. So the example here on the left is of an arthroplasty resurfacing, where just the surface of the humeral head has been replaced by this metal ball. On the right, this would be where we would use a humeral head replacement. This is a condition called avascular necrosis, where the yellow part is the bone of the shoulder, the ball, and the central portion is collapsed after the bone has died. There's two types of anatomic shoulder replacements. The diagram on the left shows an anatomic total shoulder that has a short stem to it. The bone grows into the stem. The socket you can't really see because it's plastic and it's held in place with a little bone cement. The diagram X-ray on the right shows what we call a stemless total shoulder, where there's no stem that comes down the center of the bone, but rather the bone grows in to the platform immediately beneath the ball. And on this one, the socket has a bio-ingrowth portion too. That's the metal peg that you see in the center of the socket. Lastly, you've probably heard about a reverse total shoulder replacement, and this is commonly used when the rotator cuff is what we call incompetent, like it's torn or it's going to tear, where there's excessive wear on the glenoid, where the shoulder is very unstable because this is a more stable prosthesis, or in certain fractures. And what happens in this shoulder replacement is the socket's replaced with a ball, and the ball portion is replaced with a socket. This is a diagram and sawbones of the same. On the left, we have a stemless anatomic total shoulder replacement where the ball's replaced with the ball. You can see the plastic socket that forms a space in between the two bones and cushions it. This doesn't show up on the X-ray. On the right side is a reverse. And what you can see here is the ball of the shoulder's been replaced with a socket. There's a stem you can't see that goes down the inside of the bone on this diagram. And the socket side is replaced with the ball, and it replaces the surfaces so there is no pain from being bone on bone, but it mechanically takes the place of the rotator cuff. Now we do preoperative planning, and things are getting more and more high tech. And what this is a diagram of a CAT scan of the shoulder that's used for surgical planning purposes. So it's not like the surgeon just walks in the room and decides what he's going to do. A lot of times he or she plans it out beforehand. So the diagram on the left shows a scapula of the shoulder recreated with a 3D software program for the patient's particular anatomy. And this shows a base plate for a reverse shoulder replacement and how we plan it ahead of time, so we get it in the precise location. The diagram on the right shows that replacement with the ball applied to the base plate, and we know we have it in the right inclination and the right angle front to back. So just a little bit about how orthopedics has progressed over the last 35 years, and that subspecialization has increased quite a bit. It used to be that orthopedic surgery in and of itself was a specialty, but now we've broken it into subspecial areas like shoulder and elbow, or sports medicine, or spine, or hand surgery. So a physician goes through training first, where they go to college, then they apply for medical school, either osteopathic or allopathic. Then they do their internship, which is a year of general training, and their residency. Then nowadays, most people do what's called a postdoctoral fellowship, and that's subspecialty training in a certain area. Nationally in orthopedics, it's about 90% right now. I did have dinner the other night with the head of KU's orthopedic department, and theirs is about 75% of the residents specialize. So you would look for that as someone who has either special training in their area, or they have done what's called practice subspecialization, where they've taken on certain areas of their practice to concentrate in, and they do continuing education in those areas. Also look for board certification, and then we have to recertify every 10 years. And I think that's an important part of choosing your orthopedic surgeon. So lastly, I like to give a little tribute to my mentor. This gentleman on the right is Dr. Charles Neer. He actually is considered the father of modern day shoulder surgery. He invented the shoulder replacement and other procedures that we do. And we like to think in orthopedics and in all of medicine that we really learn from those who came before. That is to say, we stand on the shoulders of others. Lastly, this is my group, Orthopedic Health of Kansas City. We're just down the street at 1950 Diamond Parkway next to Meyer Rodos. This is a picture of some of the members of my group, and we're outside of our orthopedic urgent care, which is open every night till about 8. I think that picture will change a lot in the next 10 years. There's a lot more women going into orthopedic surgery, and also underrepresented minorities. So I think that picture will change over the next 10 years. And I'm often know that that's for the better. Thank you. Now it's time for questions and answers.
So that was fascinating. I think I learned more about the shoulder in the last 25 minutes than I did in 4 years of medical school. And I always wondered what this reverse shoulder replacement was. It's just fascinating. Well, we have some questions from the audience. First question is from the audience. A person fell snowboarding and they reported that the x-ray at the slope was negative, but the shoulder still hurt and clicked 2 months after the incident. So what should this person do?
Well, I think that the fact that they had a significant injury to their shoulder, snowboarding, indicates a certain level of trauma to that. So often people will take a month or two and kind of do anti-inflammatories and exercises and that kind of things. But if it continues to hurt you, it's waking you up at night, it's interfering with the kind of activities that you like to do, you really ought to get it checked out. And you want to have a diagnosis. So you'd like to see someone that's your primary care physician or referral to an orthopedic surgeon for that history and physical exam and initial treatment, as we discussed in the diagnostic portion of this talk today. I think it's important to make a diagnosis, and like the title said, don't just shrug it off.
Now, here's another question. This patient is a 50-year-old diabetic female. She reports that her shoulder started hurting about 3 months ago, but there's no report of injury. She says that over the last 3 months, the pain has gotten worse, and now she's losing movement in her shoulder. What should she do?
Well, I think that this is kind of the classic history for developing what's called a frozen shoulder, which is the first topic we discussed. Often the pain comes on for no reason. It's usually in a female, 7 to 1 to men. It's often in a perimenopausal condition because there's hormone changes going on, which are thought to be implicated in this condition. And often it can be treated with non-operative treatment, such as physical therapy, medications, and making a diagnosis to make sure that that's just what it is and doesn't reflect some underlying condition.
Okay, that's great. So here's another question. Here, a patient was told by a doctor that they had a large retracted rotator cuff tear. This patient says it doesn't hurt very much. Is there any harm in just ignoring it and letting it go?
Well, there's two answers to that. It depends, but often there can be. If it's a fresh tear, what happens when the muscles retract is they undergo changes that we commonly call atrophy. It's thought to be due to a physiologic reaction to not having any pull on the tendon. And there's also been some evidence that the nerve to the rotator cuff, specifically the suprascapular nerve, can get on tension or kinked and cause the muscle to atrophy. So I don't think you want to shrug it off. I think you want to have a diagnosis and discussion as to what to do with that, because often you might want to have it repaired, especially if you're in a younger age group that needs that strength of the shoulder.
Okay. Another question from the audience. I have type 2 diabetes. My shoulder has hurt for over a year. X-rays show arthritis in both shoulders. Years ago, this particular person had a rotator cuff surgery on the left shoulder. Should she now seek medical advice?
Well, yeah, I think that's a good idea. The shoulder hurting for over a year is a little concerning. If you have arthritis in both of your shoulders, there's a lot of things that can be done for that. And the diabetes on top of it can lead you to having a stiff shoulder. So I think that it would be good not only to get a precise diagnosis, but to have non-operative treatment, at least to start with, such as medications and or physical therapy. If the arthritis is terribly painful and progresses, then there are also some operative options, as we discussed.
Okay, here's another question. I have, from the audience, I have arthritis and severe pain in my shoulder. This particular person is considering a shoulder replacement. What is the difference between a regular shoulder replacement and a reverse shoulder replacement, and how does the doctor decide?
Well, that's a very common question, which I probably get every day from patients in the office or in some other method like telecommunication. But in any case, the anatomic toe shoulder basically is where you replace the ball with a ball and the socket with a socket. It's commonly used in folks that have an intact rotator cuff and an intact or non-angulated glenoid, or one that can be easily corrected. We also have more of a tendency to want to use it in the younger patient, that is someone under 50 years old, because all of these replacements wear with time. And what's called the survival analysis of a shoulder replacement, that is, how long do they last, can be anywhere from usually around 15 to 20 years, but it depends on the wear of the plastic. In the reverse shoulder replacement, we replace the ball with a socket and the socket with the ball. This is a very innovative shoulder replacement that was actually designed by a French doctor by the name of Professor Gourmand in about 1984. It had to undergo a couple of decades of revisions and improvements until it was approved in the United States in about 2004, 2005. And so it's used primarily in folks that have what we call a compromised rotator cuff. It's either torn or it's going to tear. We prefer to use it in the older patient. And we also use it in folks that have severe deformity of their glenoid or have pretty bad instability of their glenoid. And so it is really a decision that the doctor and the patient make together based on multiple factors.
So this is a little anecdote. I played golf with one of your patients about 2 weekends ago. I played 9 holes and he had a reverse shoulder. He said he's pain-free and doesn't report any restriction in motion. I was impressed. He also was a very good golfer. What activities do you restrict people from if they have a shoulder replacement?
Well, the answer, again, depends on whether it's an anatomic toe shoulder or a reverse. With an anatomic toe shoulder, the primary restriction is weightlifting.
Mm-hmm.
And we have an arbitrary lifting of about 50 pounds.
Mm-hmm.
That is kind of anecdotal because a long time ago, we had some bodybuilders from California and they decided to do very heavy bench pressing with their shoulder replacement. And they actually edge loaded or wore out the socket portion of the shoulder replacement early. The reverse shoulder replacement has a little bit of a different bent to it, in that because of the design of it, where the socket is under the ball, if you do heavy lifting, just even carrying and lifting, it can cause it to separate a little. So we put them on a lifting restriction of about 20 or 30 pounds for that particular shoulder. The other thing about a reverse is the way it's designed. Some people have some troubles coming up their back, what's called internal rotation. And so that's something that we often talk to people about beforehand. The last thing with the reverse is because of the design of it, your shoulder looks a little flatter. There's no ball under there anymore. Mm-hmm. And it's a little bit longer, usually about a centimeter or so longer. So those are kind of the general considerations between the two.
My only observation about this player is that his drives were longer than mine. That's the only observation I have. Here's the final question. Are robots being used for shoulder replacements?
Well, not as much as they are like, for example, in the knee. What we find to be valuable in the shoulder are two things: either patient-specific guides, like I showed you with the diagrams using the CAT scan, where we precisely determine where the replacement should go, or there is actual real-time guides that can be used to get that precise location in the scapula. The shoulder blade, the glenoid component, is really where we have the most difficult time with precision. The humeral side, it's right there in the open. We can see everything. So the actual robot doing the surgery is a lot more common in hip replacement or knee replacement. In the shoulder, it's more like guides, either real-time or patient-specific guides that are made that assist us with placement.
So I said that was the last question, but we have one more question from an audience member. Are you taking new patients?
Well, yes, I am taking new patients, and I just opened it up. So
that's good. Well, I might need to stop by.
okay.
Thank you, Dr. Satterlee. We hope Dr. Satterlee's presentation was informative and helpful. Please join us Monday, June 13th for our next Lunch and Learn presentation, Conquering Incontinence, with Dr. Ian Rossbrew, a urogynecologist with Meritas Health Pavilion for Women. Again, thank you for joining us. Have a good afternoon.